joined this afternoon by Aashima Gupta, the Director of Global Healthcare Strategy and Solutions at Google Cloud, Matthew Roman, Chief Digital Strategy Officer at Duke University Health System, and Dr. Mona Siddiqui, the Senior Vice President of Clinical Strategy and Quality at Humana. So over the past 2 days, panels have touched on a few policy issues, but given the major digital health policy changes over the past year, we wanted to have an entire panel dedicated to the topic. Over the spring and summer, as the extent of the impact of COVID-19 became clear, Congress and state governments raced to change what were, in a lot of cases, decades-old laws and regulations around delivery of care, lab testing, and data exchange, and other issues as well. And I think the question on everybody's mind, especially everyone on the line today, is which, if any of these temporary policies become permanent, and which ones should be specific to this time, this crisis situation, but also more importantly, how do we learn from the pandemic and through public policy, build a better, more effective, efficient, and equitable healthcare system. And so our panel today is going to be very discussion focused. So if you have questions as we go throughout, pop them in the Q&A box. I'll keep an eye on it. But I'm going to start off with a few questions here for our panelists. So as I was saying, a lot of people say this year has been a turning point for digital health policy. And I think in a lot of ways it has, certainly for telehealth policy. But in a lot of ways, it has also highlighted how much is left to do to ensure technology can be utilized fully in healthcare. For example, at least in the beginning days of COVID-19, a lot of test results are being faxed to county health departments. I think we all saw those stories in the news. And so let's just level set here. Was 2020 the year of digital health? And if so, or maybe if not, where do we go from here? Maybe I'll kick off with Mona.
Well, you know, it's interesting because obviously there have been just a lot of movements in the last decade and more in this space, and last year has just accelerated the adoption of things that maybe there was a lot of hesitancy to start to use, and we've seen acceleration both in terms of the willingness of large companies like mine and others to really lean in, but also on the part of consumers to really begin to consume healthcare in a very different way. So I think we're 2021 and moving forward, I think what we're going to see is organizations, again, really leaning into seeing how we deliver healthcare in a very different way, how we combine digital tools and analytics and our traditional assets of, you know, in-person interactions, and how we lean into really designing an end-to-end consumer experience using not just one channel, but multiple channels in a way that's seamless. I think the other thing we're going to continue to see is innovation in the underlying business models that help to really accelerate the adoption of those new ways of delivering care and of working across those different channels. So I'm really excited. I think, you know, I think it's created an opportunity. I think our, you know, consumers, I think all of us are ready, frankly, and I think it is going to also really lead to some innovative partnerships along the way that healthcare needs.
Thanks, Aashima.
Thank you, Catherine, and great to be in panel with you, Mona, after a long, long time. I think, so Catherine, what we are seeing, definitely digital is at the forefront, and health systems have been at the epicenter of this fight, not against COVID-19, and they have to balance two acts. One is really take care of the patients, but also amidst substantial financial pressures. So against this backdrop, we saw during pandemic, I was part of the Cloud's COVID response team. And so against this backdrop, health system, hospitals, payers, they find themselves at a pivotal moment. And there's a realization that the future will not look like the past. And we are seeing there's a tremendous potential for digital, potential for also technologies like we offer cloud, AI, APIs to help for the fundamental shifts across the care continuum. We are seeing the shift on the virtual, digital, and hybrid care. We are seeing a focus on interoperability. Never been before, I think when you talk about policy perspective, Catherine, we've been talking about interoperability for a decade. And yet, COVID-19, it underscored the needs to really, when a patient is being seen and getting the labs from a different lab, and if I'm visiting my primary care and taking some services from the inpatient, all this data still remains pretty siloed. We have talked about it, and now the focus with the new regulations, with the ONC and CMS rules, we're seeing that will really, it's a pivotal moment for us to realize that. It is a big undertaking, but with a huge and massive impact. So we're going to see that. And the third trend we're seeing is around the whole, I would say, humanizing the operation with AI. As we all know, we talk about that as well. 80% of the healthcare data is still unstructured. It's in the PDFs, it's in the docs. What can we do to leverage technology and bring that data into the forefront with the center theme being connecting the different silos with data as a backbone? We'll continue to see that.
Great, thanks, Aashima. I know you certainly have been on the forefront of interoperability policy for a while at HIMSS and other groups. Matt, I can turn to you now.
And thanks, Catherine. You know, your question was 2020 the year of digital health? And from the angle of the health system, from the delivery system, I certainly think the answer may be a strong yes. For instance, we at our health system were doing some things pre-COVID, but almost at a demonstration project level where we had early adopters that were interested in digital health or virtual health. Some of them were because of research interests, some of them were because of particular technical interests. Some of them were for real clinical value add, for instance, with patients that have mobility problems and they had a hard time getting to our physical clinics, we could serve them better from a distance or from remote areas. And so I think that actually was certainly true for us. And we did some things, our planning at this, a year ago was to try to learn what we could about delivering care that is as high quality or better as traditional in-clinic delivery models, so that when the demand would increase in such a way that we anticipated it would over time, in other words, perhaps when our digital native patient populations became the dominant patients instead of just the youngest and healthiest that we treat, that we'd be ready to serve them. We went to great lengths to learn lessons. We white gloved everything. We basically were at a volume, a low enough volume that we're able to almost handhold patients and providers through their virtual care experiences pre-COVID. And the unfortunate piece, though, for us and maybe other systems too, was that we had our structure in place that it almost required or almost depended on this hand holding. And then, of course, in March of last year, everything blew up in terms of volume. And so we had to adapt very quickly. And our volumes of digital care or virtual health visits exploded by, thousands of %. And so we adapted and we put some things in place in a big hurry, and we learned some lessons that in 3 months that we were on pace to learn over 3 years or 5 years pre-COVID. And so in the effort to not waste a good crisis, I think we certainly have learned some lessons to apply to our current and future digital health strategy. And so it will be very exciting to see where this goes, to your original question. And I do believe that digital health is and should be here to stay. And it has certainly been accelerated by 2020, in my opinion.
Thank you for that. I think they say that public policy moves slow. I would say I think maybe healthcare is right there along with public policy, and both of those systems certainly have been turned on their heads over this past year. So thank you for everybody's thoughts. So Mona, you have focused a lot in your career on how data can be leveraged to transform the healthcare system, everything from value-based care to integration of social determinants of health data, which we talked a lot about yesterday, to addressing the opioid epidemic. And one barrier to this that eHealth has focused on a lot, and Aashima brought it up in her remarks as well, is the lack of interoperability in the healthcare system currently. And what do you think is the best path forward to achieving interoperability?
Yeah, I think, you know, what we did at HHS, interoperability obviously means a lot of different things and many different systems there. So the approach within the department was really to take a use case by use case approach, because there are obviously technical integration issues which are really easy to work through. The policy and legal issues can take a longer time. And, you know, when you sort of look at data sets that are much more sensitive, and, you know, in the 80s, there was a lot of information around HIV, for instance, that was really, really sensitive. Some of the data sets at HHS right now around behavioral and mental health are particularly sensitive and can lead to disclosure of information about vulnerable populations. So those decisions and understanding how to connect particular sets of information where you're getting the right level to make informed decisions, but also protecting the privacy of individuals at the same time, I think have to get worked out almost use case by use case. And to take a challenge like the opioid epidemic, like addressing behavioral and mental health issues, SDOH, which you saw, you know, some recent moves from HHS on that, which started about a year ago. Again, all of those are incredibly important. Data is the, you know, the sort of core infrastructure to be able to make significant gains there. But one of the things for me that was a lesson learned is while I want to make things available for consumption, there's also just so much sensitivity around what you put out that could lead to identification of individuals with some really vulnerable populations. I would say we're taking a fairly similar approach within Humana. We have probably one of the largest partnerships there with Microsoft and with Salesforce, and have invested a significant amount in creating a interoperable data infrastructure, both to support all of the different assets within Humana, but also our relationships with providers across the ecosystem. And while we're, again, making significant strides, being able to deploy that data in a way that's meaningful requires identification of use cases that are relevant to all of the stakeholders. So relevant to the providers, relevant to the different business segments within our organization, and then really at the end of the day, relevant for services that we end up providing for patients. So it sounds boring, but really it's the right approach in figuring out what are the services that we need to provide for individuals at the end and for the users, and then how do we bring everybody at the table early on in so that compliance or legal or privacy issues don't end up being the barrier in how we think about connecting information. So when I think about it much broader than just interoperability, for instance, of EHR data, right? It's healthcare data is just a much broader ecosystem now, and thinking about how we merge those sources of information require experts from multiple domains to be at the table.
Thanks, Mona. That's great. I think we actually have experts from multiple domains at this table right now. So, but I did actually want to follow up on that because you are also a doctor, Dr. Mona Siddiqui, as I introduced you. And one barrier that we hear a lot is that providers have a general lack of confidence in the data that they receive from non-traditional healthcare actors. I mean, you mentioned that there are a lot of data now outside of the EHR, especially around social determinants of health and the in the opioid epidemic and behavioral healthcare settings that might be outside of the traditional healthcare setting. And so in your experience as a provider, how do you think that this can be addressed, just this general lack of confidence in the data that's coming in? I think these kind of go hand in hand with the interoperability issues too.
Yeah, that's a great question. So more information isn't always better, right? I think there can be information overload. Part of the challenge, I think, is, and it's a good challenge, it's a challenge we should take up, is how do you demonstrate value from the multiple sources of information that are getting provided? Now, just because I have access to free text that somebody has written doesn't mean that as a provider would be helpful for me. A lot of that information is getting, cut and pasted from note to note. And I think as we bring in other sources of information that, quote unquote, non-traditional sources of information, the challenge is also to show the providers that if you use this, that it can have a meaningful impact on the care that you're able to provide for your patient. There's a similar challenge, I would say, even sort of behind the scenes from the payer perspective. When you look at the multiple sources of information, it's not always clear that which ones might help you in doing better in predicting a health event. There's sort of the traditional sources that we use and saying, how do we proactively reach out as a Medicare Advantage plan to help our members in better managing and being proactive in their care? Well, we know how well we can do with the traditional sources. Sometimes when we take these other sources, the question really ends up being, can they help you do better than where you currently are? And the answer is not always yes. So, there's a balance in really being able to test when you bring these other sources, what is the value added for the additional burden of the information, and really making sure that information can lead to an action that someone can take. So I think it's a more nuanced conversation than the providers aren't accepting. I think it's also around, are we presenting the right sets of information? Have we demonstrated that the connection of those sets of information can actually lead to an action that is going to be meaningfully different than what they would have done in the absence of that information?
Mm-hmm. Great. I wanted to give you an opportunity to respond to that just from your health system perspective, but also wanted to talk to you a little bit about what you hit on earlier, which was your rapid deployment of digital health, in particular telehealth. And a lot of people know, and you mentioned earlier, that before COVID-19, telehealth utilization was fairly low, though growing steadily. But during the pandemic, utilization skyrocketed. I think you mentioned by 1,000% at Duke. So from a health system perspective, can you talk a little bit about how you did utilize telehealth pre-COVID, expand on what you were saying earlier, and how you changed once the stay-at-home orders went into effect?
Yeah, thank you, Catherine, and I appreciate the opportunity to come behind Mona too, because she said some really, really powerful things. I completely agree that more information or more data is not always better. There certainly are times when we can and should, from a technical or a digital standpoint, limit the floodgates and then just give, that's a little bit jargony, but sometimes people would call it actionable data to a provider, meaningful clinical decision support types of data, aggregated and visualized handily to a provider who is oftentimes very busy through the day to support a clinical decision, as opposed to simply providing loads and loads of information on which we would then expect that provider to make a decision. So more is not better, but quality matters, and what you give and how you analyze even before you put these data into the hands of the provider is sometimes helpful. And it's interesting also, not only can you use these data before they get to the provider to predict some bad outcome, but I would actually advocate that extra data sometimes not necessarily not in front of the eyes of the provider, but normal data is helpful too, to anticipate and to be able to make decisions on blips in data that might actually be not meaningful. So there's one piece of this that's helpful to predict a bad outcome or a downturn. There's others there are other data points that if in fact we get, or when we get to the place where we've seen enough of them to be able to say, this is somewhat expected. And it really doesn't so much mean much, that not to be ignored necessarily, but to be almost discounted, I think is an important piece. And then on the last thing there is, it's not just in my mind interoperability between electronic health records. There's piles and piles of information, and Mona alluded to this also. There's piles of information about our patients that is never found in the health record. I was in a conversation with a colleague of mine, a very clever, very bright, somewhere about 40-year-old person and gentleman. And he said to me, you can study my health record all day long and you won't learn much about me. And his point was, he's healthy, right? There isn't much there. And so there's not much on his health record or many people's health record to actually predict future health outcomes, because there's no history of. But there's plenty. And he went on to say, if you want to learn something about my health outcome or any predictable event, watch my MasterCard or watch this or that or the other. So a social driver to be able to understand. And while I completely understand and respect and value the importance of privacy and data security, there's plenty of value in combining non-traditional information, meaning things that aren't typically in the health record, from social drivers, from other sources around the individual themselves, to help us make good decisions about improving care and outcome. And then just briefly to what we were doing pre-COVID in healthcare. I mentioned some demonstration projects. We were doing some things with, for instance, one of our earliest adopters in our health system is a neurologist who treats Lou Gehrig's disease, or ALS. And these are patients that with advanced stages, tremendous mobility problems, oxygen tank requirements, all these sorts of things. And this particular provider sees patients from our entire region, multiple states, in fact. And so he's been able to extend care to these patients without having them have to come to the clinic to be able to see them. And thinking to go to the primary care clinic for you or me is it's almost a non-event. But for a patient with advanced stage ALS who needs 3 caregivers and 6 tanks of oxygen and an entire day or day and a half to get to and from the provider, the ability to see that provider with some frequency from his or her home is tremendous. And it's a remarkable difference in the quality of life that person has and the quality of experience with their provider. So things like that, we're doing some things with high-risk obstetrics, for instance, where a patient was seen in her local obstetrician's office, but be able to see same time, real time, their obstetrician with our high-risk OB tertiary care doctor, do a combined examination and make determination right then and there, are you safe to deliver in the local community hospital, or must you come here where we have tertiary facilities and have a neonatal intensive care if necessary. It's things like these that make real big differences. And then we ramped from there. We saw after the stay-at-home orders went into effect, and this is not an exaggeration, we saw more patients the first day before noon after stay-at-home orders than we saw in the entire month of January 2020 by video visit. And these are spread across all specialties, primary care, every specialty. And we did for reasons that everyone on the call can anticipate, to reduce exposure. Of course, at the time, if you think back into March last year, There was so much that was unknown about COVID, and so much we needed to continue to do with and for our patients, but wanted to reduce or limit exposure to the patients and to our staff as much as possible. And so it blew up in a hurry.
Well, thank you, Matt, and I appreciate those stories as well. I actually started my telehealth advocacy career at a Parkinson's advocacy organization, advocating that people with Parkinson's should be able to utilize telehealth in their homes for all of the reasons that you stated. And especially you mentioned your specialist, your neurologist treating across state lines. The state licensure requirements are some regulations that I mentioned earlier. A number of them were relaxed during COVID-19. I think those have started to go back into place. Some are still under emergency orders to waive some of those, but those are certainly not new battles. They're fights that we as telehealth advocates have been fighting for 20 years, well, not me for 20 years, but 8 years now. And I think before COVID, a lot of people understood why those barriers for people with ALS or for people with Parkinson's, specifically around Medicare reimbursement, removing the requirement that a patient be located in a physician's office, because even like you said, for a person with ALS to leave their house to go to a physician's office is a struggle. Even if it isn't just to travel all the way across the state, it's still quite an effort. And so what are your thoughts about, now that everybody has seen the value of telehealth for all conditions, do you think that these policies should revert back to how they were, these small pilot projects, or do you think we've learned enough to inform public policy moving forward to remove some of these barriers?
Well, I strongly believe that some of the relaxed changes should remain permanent. And you said it right. These rules were not revoked; they were relaxed. The enforcement of them were relaxed, and so we have to be really very mindful of what that really means and the difference. There are pros and cons of changing medical licensure to practice across state lines. There's a lot to unpack in that. Both from the sort of regulatory as well as the provider side angle. I think the data that we have collected from our own practice, as well as the data that are published across the country around certainly satisfaction, both from the provider and the patient side, strongly suggests that care, we should be able to continue to provide care across telehealth in a much more relaxed manner than we did before. We are doing some things to try to make certain that we're encouraging video visits and telehealth encounters when, in fact, all the holes of the T's align. In other words, when the patient has the necessary technology or we can provide it, when the patient may have a preference, when they are seeking care that can be delivered safely and effectively and in good quality across a video visit, then we offer it to them. And when any of those things and a few other bits of the puzzle are not present, I'm seeking care that simply requires a physical or so requires to be in the room with the provider, then we ought to be smart enough to not even make that option available to the scheduler or to the patient, him or herself. And so we operationally use this intelligence to then route the patients who need the care to the physical visit. And then those that need care or are seeking care that can be delivered digitally can be handled in that way. So I believe that we have learned enough and we'll continue to learn. And with some additional time, we'll be able to demonstrate quality and efficacy. And we ought to be able to also demonstrate equity of access to make certain that the same level of care is available to all segments of our population. And as those things come out to be at least non-inferior, right? And in fact, sometimes I believe we'll show some superior results from video visits, at least non-inferior, then these things ought to move forward together, in my opinion.
Yeah, and I think that is important in your last example there of using your own professional judgment is something that EHI has been saying for a long time, why these barriers should be removed, because Congress and CMS really only have blunt instruments in order with public policy. And so let's remove some of these barriers and leave it to standard of care and professional judgment, with, of course, protections for patients around fraud and abuse, and for payers. But it really should be up to what you were saying, professional judgment, and that's what we've been really advocating for. The last story I'll say in terms of showing better quality is when I first was working on telehealth with a movement disorder specialist at Johns Hopkins. He had a small pilot study, like you were saying you were doing, and one of the outcomes that, not statistically very relevant, but he liked to tell, was that one of his patients that was in the control group, still going to him to see him in the clinic, was actually unfortunately, he was okay, but he was in a car accident on his way to the doctor. And so like those types of stories really highlight why this is so important. So I appreciate you giving those stories as well, Matt. To shift gears just for a minute to Aashima, I think that you have a really unique role with Google Cloud, and that you're able to witness how technology is currently being used across many different healthcare systems and actors, and even outside of healthcare, as folks are saying, that there's so many non-traditional healthcare data sources now. But we've talked a lot about technology and data in different buckets, because generally that's how policy gets made. Is, you have an interoperability bill, you have a telehealth bill, maybe they come together, but that's, regulations, that's how they work. But how do you think that we tie this all together to reach the ultimate goal, which I said in the beginning, delivering high quality, affordable, equitable healthcare to patients?
Thank you, Catherine. I couldn't agree more with some of the comments that were made earlier with Mona and Matt. Like when I work with large health systems or across the care continuum, people are all looking for more data. They're looking for, I heard someone say healthcare is a data rich but information poor industry. So stepping back, what these rules, the interoperability, are not, they're means to an end, but they're more than a regulation. So I would go back, can we leverage interoperability as a blueprint for a learning health system with critical data flow and access capabilities, not only to tackle the future crises like what we saw in COVID-19, but also reshaping industry for the longer term. And I see three ways how interoperability and kind of tying it all together. Number one is the vision of digital health economy and democratization of innovation. Just like we saw telehealth emerge, we are seeing new initiatives in digital front door and many different apps emerging. And the core idea here is that healthcare patients and consumers like you and I, we deserve the best innovations as we continue to transform from paper records to a digital journal or digital record as we are creating it. So the core of that digital health economy is the idea that the data can flow to where it is needed. Well, it's about generating more data, but it's also about making that data available at the right time, in the right setting, in that critical data flow. That's where interoperability and APIs become very critical. So we must, as a community, embrace the premise that health data can and should move to where it needs to go. And the whole premise of this regulation is, as a consumer, with my consent, I can share the data with my physician if I deem that it is useful in managing my care regime. So think of regimen. So empowerment and empathy, they go hand in hand. So we need to empower our consumers, and interoperability kind of speaks to that. The second is we also, during COVID, there were healthcare infrastructure resiliency was really put to test. Industry did great, and now when we're thinking post-pandemic infrastructure resiliency, data will be a critical part of that. Be it, how much ICU capacity, where the vaccines need to go, the supply chain, and the whole public health angle has come to forefront, and data has been important to understand across these different systems, and have the collective view. So that's the second thing from the infrastructure resiliency perspective, having that bird's eye view of how the data and how to manage that interoperability will be important. And the third, I think we touched upon that, rethinking chronic care, rethinking, because as we all often talk about, health doesn't happen the 2 times you visit your physician, and we're seeing with virtual care and telehealth that barrier being even further reduced. So imagine a telehealth visit, talking to your physician or your nutritionist, or and your latest information is not there, your latest lab results are not there. So we believe very strongly that in the telehealth and the new experiences that are yet to be created, bringing the data into that experience will make that interaction much more meaningful and impactful. So just to summarize 3 things, the vision of interoperability is going to be the cornerstone for the learning health system. First, in creating that digital health economy and a platform where innovation can come from anywhere, be it your health system, be it startup, be it any other entrepreneurs, and creating that platform. Number 2 is around creating that infrastructure resiliency. And number 3 is rethinking chronic care and rethinking how we can empower the telehealth experiences with more relevant data.
Great, and I actually, that tees up my next question perfectly, but just wanted to remind folks that if you have any questions, we are going to open it up to panel or audience questions, so you can put them in the Q&A. We have great panelists here. We're happy to answer your questions. But building off what you're saying, Aashima, I wanted to ask each of you about something that I've been thinking a lot about recently, which is the future of value-based care. And as a payer, a health system, and a technology vendor, you all have a critical role to play in value-based care. And I believe that most in healthcare support value-based care, and they believe that that's ideal versus a fee-for-service system. But I do worry about the future of these value-based care models, just given the immense financial impact of COVID-19. I was worried about that earlier this summer, not even taking into consideration the second wave that we have now. But that being said, I think many current value-based care models are not immensely popular. MIPS under the macro law, for example, not very popular across providers or some even policy-minded folks now. But do you think that this COVID-19 pandemic provides some sort of reset or an opportunity to revisit the current models to improve them? And if so, how would you change policy with relation to digital health to improve the models? And maybe I'll kick it over to you first, Mona, since you've at HHS been a part of some of these discussions from the inside.
Yeah, I mean, I don't know that anybody would disagree that we need to move more fully into value-based care, right? Now, everyone may define that slightly differently, but ultimately, we want to make sure that the system is one that rewards improved outcomes and promotes cost efficiency and decreases waste, right? Those are things that I think we can all align around. The question becomes how we get there as a ecosystem. You know, in my current sort of position, we would say that there are some providers that are sort of taking full risk. There are others that are on the path to that. And we think that the right approach is really to partner in that process. And I think that's actually the challenge, which is not that I think anybody would fundamentally disagree with, you know, how we pay for better outcomes and decrease the waste in the system. It's in what's the right path to get us there. And depending on where you are in your practice, depending on which part of the country you're practicing, depending on whether you're a solo practitioner or you're in a large provider practice, depending on the support that you have in that infrastructure, that can look really different for you. So, you know, really, I think partnering with, from my perspective now, partnering with our providers to understand what is that right pathway, I think is really, really important. And I think keeping the dynamics of what that practice is trying to achieve, understanding that one size doesn't fit all, is going to be really important. I think when it is more restrictive, and obviously we want to accelerate that path for the entire ecosystem. I think we all are impatient to see healthcare just move more quickly in all fronts. But I think at the same time, we have to make sure that there's an enormous change management actually underlying all of this that we have to be cognizant of, and many different parts of the system that have to work to get us there. And information sharing is fundamental to that, right? So unless we can say that we're providing the right information to these, you know, to these providers at the right time for them to be able to change the way that they are practicing, the actions that they're taking, it's really hard to say that you can go to ultimately just looking at, you know, the outcomes as a measure of how someone is doing. So there has to be a commitment to enabling those providers with the right information at the right time. So you know, we can't just say here's the policies, here are the regulations. Now, you know, figure out how we're going to implement that. There has to be a path to get us there.
Anybody else? Matt, Aashima, I wanted to weigh in, future of value-based care.
I think what we see, and then I have a kind of slightly unique perspective because we hear and work alongside many of our customers. They are looking for those value-creating partnerships, whether or not it's full value-based care migration or but what we do see, they're looking into these value. There's more payer-provider collaboration that have come forward, and when we talk about chronic condition, when we talk about where to provide the right care at the right setting to the right patient, when you look into that and to have the holistic view, these partnerships are being formed. So to Mona's point, it is about doing the right thing, from providing the access and compassionate care to the patients. And if that means that the patient has left the four walls and have gone to a different clinic, or they're going to the pharmacy, connecting that, I think that's the whole, we are seeing a lot many initiatives now that our customers are undertaking are about these bi-directional data exchange, bi-directional from the sense that from a consumer perspective, knowing the patient journey, creating that longitudinal record, and to us, the longitudinal record where you can actually help the patients along the journey, but also help predict and help them, giving them meaningful tools to help empower them. We definitely see that a lot when I talk to and seeing their strategic initiatives. Is definitely a lot more from the patient centricity perspective.
Thanks for that. Yeah, Matt, I'm interested in your perspective. I specifically mentioned the financial impact of COVID on health systems. So I'm interested to learn if you all are forging ahead, reevaluating.
Well, I find myself somewhat violently agreeing with the others, that I think that the idea of paying for outcome is very comfortable and in fact absolutely essential. And I love when Mona put in not only paying for outcome, but also the other bit about reducing waste is important. I think, though, there's opportunity and maybe even necessity for some somewhat significant structural change from all sides of this equation, from us on the payer side, the provider side, from the payer side also, and from the technology industry, both in terms of, you know, devices that are that are developed, and uses of data and technology and data science and things. Aashima mentioned adding value, which I think is really a critical piece to this. Of course, that's a hard term to define, but it's essential. Mona mentioned earlier hesitancy to adopt. I think we ought to continue to address that and show. One way you address hesitancy to adopt from a patient or a provider side is to show good quality outcomes. I think we should look at some of the rules that are in place, and I believe there's ways to address waste by, for instance, right now a provider rather can get paid for remote patient monitoring only after a person has been diagnosed with a particular condition. So maybe there's value actually in remotely monitoring data, biometric data and/or ambient data in a home before they actually get sick, and learn some things from trends and identify illness or a person that's decompensating much earlier and intervene much earlier, and there's opportunity to save there. So I think before chronic condition is diagnosed or acquired, perhaps there's opportunity to change the paradigm of how we address and use technology there. This could lead to predictive modeling. It could lead to risk adjustment and much earlier interventions, I think. I think perhaps we have opportunity to combine with behavioral modification approach. People are very loss averse, and if we can show that they're about to become, or if they continue on a particular, they will be type 2 diabetic, and all this, some of the sequelae of that if they continue their particular lifestyle choices for another 20 years. That might not be a quick turnaround or a quick return on investment, but these types of things can actually make a difference. Of course, to close the loop with the earlier conversation, we need to respect privacy and security and identification of the people. Location tracking. If I'm an asthmatic person and I spend a bunch of time in an area of town that has lousy air quality, that matters, and that's going to impact my outcome, and that's going to impact the trajectory of my care. I'll have a higher incidence of admission or ED visits. Any of these sorts of things where you can combine digital care, technology, good, solid, clinical quality decisions and outcomes. All of these, I believe, fall under the value-based care umbrella.
Add to that, Kathy.
I would completely agree. What was that, Aashima? Sorry.
So no, I was going to say, I think just to add to what Matt was saying earlier, there's that rethinking of how to deliver care, especially chronic care, and the move to something that is more continuous with digital tools to monitor diabetes, blood pressure, and those disease state monitoring with the right tools, and also providing the online guidance. So we are seeing that, whether you can call it value-based care, but there's tremendous shift in rethinking chronic care and rethinking how to deliver care in this hybrid setting. And I believe we will see a lot of different business models emerge. We will see a world where there's a huge opportunity to use the data and the relationships and payer provider networks to help with the early detection, prediction, and intervention, and get inspired by these conversations.
And Catherine, the very last thing I'd like to add is, if done correctly, given the ubiquity of technology, these types of approaches can be a great equalizer and can address disparities in care, which is really very critically important to us, and can lead to public health initiatives and things to address some of the root causes of some of the problems we're facing. So anyway, sorry for adding too much.
No, I think that's exactly right. And that's what I was going to say too. I think if we want to get to the system and that we are all talking about, especially providing earlier preventative care, doing that in a value-based system is going to be key, because all of these tests and remote patient monitoring devices everybody was mentioning, I don't think anybody has an appetite to pay for this in a fee-for-service system across the board for everyone. But in a value-based, risk-based model, I think those start to make more sense. And turning digital tools, which providers have been, I think, rightfully frustrated with for a long time, because they became, just check the box type of activities, but really showing how they can transform care. I think that's going to be key in a value-based system. Okay, so we have one question here for our panelists, and I think this is actually probably, I'm going to direct this to Aashima, just given that you are with Google. Sorry to put you on the spot here. We have a question here in the box about combating misinformation, and that a lot of people now are going to sources outside of their healthcare providers, internet, to search for health information, and there is a lot of misinformation around especially now with COVID. Where are the guardrails to avoid misinformation or misinterpretation of information from various digital apps and services?
That's a great question. And from Google's perspective, I am from Google Cloud, but I can tell you our Google Search, YouTube, Map teams have been working in providing helpful information. Tremendous effort has been underway in during COVID, providing guidelines, research, and being helpful. And now we're looking into, I think Sundar just published a blog 2 days ago around vaccination sites near me. So at the end, it's a big project with big undertaking. However, that's core part of Google's overall mission, which is to really help connect this information and make it more accessible and useful. So you will see more both from our YouTube teams in really surfacing the right content, reducing, and so they have this framework. It's called 4 R's, and you can. I'll send the link around how we think about it from our consumer properties in both Map, YouTube, and Search.
Thank you. Well, we're coming up on time. Maybe I'll just ask you guys each one last question. If anybody has any other questions, to throw in the Q&A box, now's your chance. Just one last question as we head out here. We have a new session of Congress, a new administration. Certainly healthcare is at the top of everyone's mind right now. What would you want to see in the first 100 days of this new administration when it comes to healthcare policy? Don't all jump in at once.
From a payer side, simply, I think some attention to the relaxation of the rules that you spoke about for telehealth and things during the emergency use authorization. I think thoughtfully considering what of those could or should be permanent. I think site of service, these types of things that's rather low-hanging fruit. Interstate licensing is not low-hanging. It's too complicated to call it that, I believe. But site of service restrictions. Like
I still have the scars from those fights.
Yeah. But I think there are some low-hanging ones that we're in a good position to anticipate or expect that they could be addressed, even in this environment.
I think just to jump in here, I would say no rollback of telehealth relaxation. So if there's 2 words, telehealth, no rollback, I think that sums it up for me. That's.
Mm-hmm.
Yeah.
And I just remind everyone on the line that Congress has to pass a law to address that. So join our efforts at eHealth. Go ahead, Mona, sorry.
Yeah, no, I would agree with both those sentiments. I think digital should have the level playing field. And I think there's often been just a much higher bar to get things approved than in-person care. So my hope is that people begin to see last year as a proof point of what's possible and continue to enable greater access to care for people through technology and through the digital solutions. And even apart from digital, I would say I know that this is a priority, but I hope to see some action and just greater expansion of coverage for people, right? So that's, I guess, my broader hope in terms of the work that this administration is able to accomplish.
Well, certainly important from a health equity standpoint, as we all were mentioning earlier. And I think actually today, President Biden is signing a number of executive orders focused on that issue around expanding Medicaid, encouraging expanding Medicaid options, and giving back some of the funding to the exchanges and education and outreach efforts around the Affordable Care Act that have been rolled back over the past 4 years. So I think those are certainly things that we're excited to see. Okay, well, with that, I guess I have the pleasure of not only closing our panel, but the last 3 days of our annual conference. Thank you to our panelists, and thank you to all of you who've joined over the past 3 days. Don't hesitate to reach out to me about any policy issues. And of course, take a look at our website. We have a number of work groups and educational webinars coming up, and we hope you can join us for those in the future. Thank you, everyone. Have a great afternoon.
Thank you.
Thank you.